So now we are going to have this talk about how to overcome the challenges in treating pigmented lesions with lasers. And we know that sometimes treating pigmented lesions with laser is a big challenge. Sometimes we have lesions which we do not know if it's going to respond well to the laser or no. Sometimes it's present in a very critical anatomical location near the eye or whatever. And sometimes it's part of a larger syndrome like the giant pigmented hairy nevus, which has the potential risk of turning into malignant melanoma. So sometimes it's really challenging to use the lasers for treating pigmented lesions. And part of the problems we face is that sometimes we have the resistance. So some lesions, some pigmented lesions are not responding as good as others. Sometimes we can treat lesions, but then they are going to have high rate of recurrence. Sometimes it's going to be associated with complications, whether it's darkening or post-inflammatory hyperpigmentation or scarring and so on. In many cases, we have a problem with the patient's expectations. Sometimes the patients are having very high expectations, which are not realistic. And one of the big issues is that the indications for those devices are limited to the pigmented lesions and tattoos. And this will lead to low profitability. And one of the comments I have received from colleagues in many cases that this is the machine which is having the least amount of profit in our practice. So this is an issue or a challenge in using those machines in our practices. So when it comes to profitability, when are we more profitable? It's very important for us to be able to provide efficient and safe treatments. So the treatment efficacy and safety is very important. So it's very important to make sure that we are able to get the best outcome of the machines we are using for treating pigmented lesions in order to be profitable and successful. We have to know the limits. We shouldn't advise the patients or promise the patients results we are not sure that we are going to get it. Otherwise, the patients will be frustrated, and this is going to lead to unsuccessful practice. Extend the applications of our devices in an ethical and successful way. So if we are able to increase the limits of the indications when we are using the lasers used for pigmented lesions, then definitely we can increase the profitability as long as we are doing it in a scientific and ethical way. We should be able to give our patients realistic expectations. How many sessions are required? What are the end results? Are we going to clear off the lesion or no? Will be there any possible complications or relapses or recurrence? All this information is very important to be given to the patients for having realistic expectations. And when we look at the treatment indications for those lasers, it's mainly the benign pigmented lesions, which might be epidermal, like lentiginous, whether it's solar or senile, freckles, café au lait macules, nevus pilus, and seborrheic keratosis. All those are epidermal lesions which are easily treated. But when we have a lesion like the seborrheic keratosis, it's very important to know what type of laser should we use, because with a lesion like that, if we use the Q-switched lasers, which are commonly used, we are going to get rid of the pigment, but the thickness of the lesion is going to remain as it is. So if I have the choice and if I have the tools, then this is a lesion which I would do ablation for with an erbium laser, for example, or a CO2. Not with the Q-switched lasers, because at the end of the day, we'll get rid only of the pigments, but the lesion will remain on the skin, and this is not going to be very much appreciated by the patients. Then we have the dermal lesions, where we need the Q-switched lasers for deeper penetration of those lasers, and this is the only way to treat those lesions like the nevus of Otta or Ito or blue nevus. So we need the Q-switched lasers, and nothing else will do a good job. Then we have the dermoepidermal lesions like melasma, post-inflammatory hyperpigmentation, Becker's nevus, and compound nevi, and those might be the most challenging, and sometimes the results are not very we are not very able to predict the outcome of the laser treatment. It's very important to remember that when we are using the Q-switched lasers, how the lasers work. We apply a laser pulse to a pigmented lesions, then we'll get fragmentation of these pigmented lesions and the melanin, and then finally those fragments are going to be phagocytosed and eliminated from the skin. And what is the importance of that? Actually, two things we have to expect. Number one, we'll get a degree of worsening of the pigmented lesion before it improves. Why? Because instead of having a collection of melanin, or pigment or ink, we are going to scatter that. So some of the pigments are going to go up to more superficial level. So this means that it's going to be more apparent. And some of them will go to laterally. So the lesion is going to look larger than before the treatment. So the patient has to expect that during the course of treatment, the lesion might look worse after the laser treatment before it starts to improve. If the patient are not expecting that, they will think that the lesions are becoming worse after the laser treatment. But if they know it and they expect it, then it is okay. The second thing, because there is an internal body mechanism involved, which is the phagocytosis, it's very important to space the treatment sessions 6 to 8 weeks interval. So we should not treat every 3 or 4 weeks like the other laser procedures. It's very important to keep enough time for the phagocytosis to happen and to take place. Otherwise, we might have higher incidence of post-inflammatory hyperpigmentation. So those are two very important things. When we have lesions like that, epidermal, lentiginous, usually it's one session. Sometimes we might need more than one session, but it's very successful. It's not only the lasers. We can do it with chemical peelings and other procedures, but the Q-switched lasers, which are working on epidermal level, are going to be the best. This is another example. Patients with 2 sessions, we can get a very significant improvement in the lentiginous on the hands. So this is a very successful practice. When it comes to café au lait macules, which are epidermal pigmented lesions, they respond very nicely to the laser, but the problem is that the recurrence is very high. Almost in 95% of cases, there will be recurrence within 1 year. So it is not a problem as long as we know it and we tell the patient about it, but if we don't tell the patient, then they will not be very happy and very satisfied. So it's very important to know that the recurrence is going to happen in most of the cases within a year. For nevus of Otta, which is very close to the eye, this is a lesion which can be treated very successfully using the Q-switched lasers, especially the Q-switched Nd:YAG laser for the deeper depth of penetration. When we are working close to the eye, it's very important to make sure that we are protecting the eye properly and we are aiming the laser towards the bone. If we have to treat the upper lip over the eye globe, then it's very important to use the intraocular shields. Treating tattoos, the amateur tattoo, we'll see that immediately the tattoo is going to have whitish coloration on the impact of the laser, and many patients will think that they got rid of the tattoo immediately. But this is not the case. This is a very temporary reaction, but then the color will come back. So it's very important to tell the patient that this immediate improvement of the tattoo is a temporary reaction which will go away after some time. And this is immediately how it looks. It's very important to see this white coloration of the tattoo. If we didn't see that, then it means that the energy utilized is not enough. So it's very important to see this endpoint. Otherwise, we are not going to get good results. And then after 5 sessions, we almost get rid of the tattoos. The amateur tattoos respond much better than the professional tattoo, and they require less number of sessions. Every time, we have to increase the fluence a little bit in order to get this endpoint. Again, this is crucial. Otherwise, we are not going to get the same improvement as the first few sessions. When we have red tattoo, then we need the 532. For the other colors, the 1064 will do a good job. With the red tattoo is a little bit more resistant, so we can see that most of the green or dark tattoo has gone, but the red is more resistant, so it needs more sessions, and this is the endpoint. Regarding Becker's nevus, this is a challenge. It's a compound pigmented lesion, and in many cases the patients are not very happy with the outcome because the response is very heterogeneous from one area to another. So we try to convince the patient to leave the nevus by itself, not to manipulate it. If they insist, then we go by segments. So we try to treat 10 centimeters square, and when we go to the down, the bottom line and the complete response on this area, we can move to another region of the same lesion, and this is how we should treat the Becker's nevus. Usually it's taking a large part of the skin, and the outcome is not going to be very homogeneous. So it's very important to make sure that we are treating by segments if the patient insists for that to be treated. Post-inflammatory hyperpigmentation and melasma respond unpredictably to laser treatment, with the lesion darkening, lightening, or not changing at all. And repigmentation is the role, so those are a bit of challenging cases, and we have to be careful. Usually we have to start with a test area and follow it up to see if it's going to clear or darken or how it's going to respond before we treat the whole lesion. When we use the lasers, the ink particles in the tattoos will fragment, followed by macrophage engulfment and gradual clearing of the tattoos, and eventually the tattoo ink appears in the regional lymph nodes and of the tattooed patients. So it's very important to keep in mind that if we have large tattoo like that, not to treat the whole tattoo. Otherwise, we'll deposit a lot of fragments of ink in the regional lymph nodes, and this might lead to foreign body reaction in the regional lymph nodes. So it's very important to limit the area of treatment to about 10 centimeters square per session and keep the sessions on 8 weeks interval. Sunscreen is very important when we are treating any pigmented lesions to avoid hyperpigmentation or post-inflammatory hyperpigmentation. Bleaching cream may help to get better and faster effects, and sessions are repeated on the same previously treated every 6 to 8 weeks. Hypopigmentation is a common side effect occurring in about 50% of patients treated more than 5 to 7 times for tattoo removal, and this is going to be reversed within 1 to 12 months. So the patient has to know that sometimes the hypopigmentation might stay for about a year. Any suspicious lesion has not to be treated except after taking a biopsy, and complete surgical removal of atypical nevi is often recommended, especially if they undergo changes in appearance. And giant pigmented hairy nevus should never be touched with the laser because they have a potential risk of malignant melanoma. So even if it is a small solitary lesion, we shouldn't touch it, because if it turns into melanoma, then we are going to be blamed. So this is a lesion which we transfer to a plastic surgeon and we don't treat with the laser. Cosmetic tattoos and eyebrow tattoos sometimes will change in color after using the laser because of the oxidation of the ink particles. So it's very important to treat a very small area as a test, see how it's going to respond, and then treat the whole lesion before we treat the whole lesion at once. Also, the cosmetic tattoo in the lip line sometimes will have color change, so it's again very important to do a test area to make sure how it's going to respond before we treat the whole lesion. Now, there were some trials to improve the outcome of the Q-switched lasers, like using different Q-switched lasers in the same session. One is targeting deeper layers of the lesion, and then another pass with more superficial, as we are going to see later, using Q-switched lasers with diascopy, where we press the pigmented lesion with a glass slide and fire the laser over that. This is going to squeeze the blood outside and keep the pigments in a more superficial layer, so the treatment is going to be more effective and the reaction of the tissue will be much better. Using a Q-switched lasers associated with fractional Erbe-Miag, which will create the micro channels for sloughing of the pigments, and again, there are a couple of studies about that, and it's very successful. The R20, where we are doing 4 passes over 20 minutes interval, so that we are getting a much better result. And then the picosecond lasers and fractional Q-switched lasers is a new modality which is still under investigation, but there are a couple of machines already in the market. Regarding the pico story, my take on that is the price is still very, very high. Sometimes we have question marks about the stability of the systems and the power. Are we going to get enough power? So the current systems in the market are having only 0.2 joules, so that in order to get 6 joule per centimeter square, we have to use the 2 millimeter spot. With 3 millimeter spot, the maximum fluence is 2.8, which is not going to be very effective sometimes in treating pigmented lesions, especially if it is deep. With 4, it is going to be 1.6, which is not very enough. So you have to use a very small spot size to be able to get effective fluence, and this is not going to be associated with deeper depth of penetration. So this is a challenge with these lasers. Green toning is a technique where we are using 2 passes of laser. The first one was 1064 for pigmented lesions, and then the second one was 532 with very low energy, 2 joules with 8 millimeter, and 0.2 with 8 millimeter with the 532. It's indicated in melasma, vascular melasma, and dermo-epidermal pigmentation, where we can get very nice clearance of superficial pigments and even in melasma in 3 sessions. So it's a very simple technique where we can use the laser for improvement of melasma in 3 sessions with this very simple technique. Some new indications to increase the scope. hair removal, trichostasis spinulosa, rejuvenation, and scar treatment. And it is a very big challenge to treat fine hair in dark skin because the parameters utilized are very contradictory between the fine hair and the dark skin. So the Q-switched Nd:YAG has been used with very nice improvement. And keep in mind that it was the first FDA-approved laser machine, a Q-switched Nd:YAG with carbon suspension, but it did not provide permanent hair reduction. So this is the improvement we can get with the Q-switched Nd:YAG, which is very resistant